Hi, I'm Dr. Arlene Chapman, Professor of Medicine, Chief of Nephrology, and Director of the Clinical Research Center at the University of Chicago. I'm also a workgroup member of the KDIGO 2025 Clinical Practice Guideline for the evaluation, management, and treatment of autosomal dominant polycystic kidney disease. In this video, I'd like to share some key takeaways for pregnancy and reproductive issues in ADPKD. Our first point of focus is hormone therapy. When considering hormone therapy in women with ADPKD, liver imaging should be performed when feasible to document liver cysts and possible polycystic liver disease. It's this protocol that should inform discussion about options for contraception, hormonal replacement, and other medical indications. Our next takeaway concerns preconception counseling. Preconception counseling for people with ADPKD addresses a range of topics. These include medication adjustments for women, information on reproductive options and potential pregnancy outcomes, and the distinct risks anticipated for both the mother and child at risk of inheriting the condition. This counseling should be offered to men and women with ADPKD who are of reproductive age. Our next takeaway focuses on reproductive options. Reproductive options without testing of the fetus or an embryo include accepting a 50% chance of offspring being affected with ADPKD when combined with egg or sperm donation from a donor not affected by ADPKD. There are reproductive options for the testing of a fetus or embryo, which include pre-implantation genetic testing and prenatal testing. We highlight these figures so that people with ADPKD can make informed reproductive choices. Next, we look at the management of ADPKD during pregnancy. Pregnant women with ADPKD should be monitored for several markers: blood pressure, kidney function, soluble FLT to placental growth factor ratios, and proteinuria. This is similar to pregnant women with chronic kidney disease. Low-dose aspirin, 75 to 150 milligrams daily, should be prescribed from week 12 to 36 in pregnant women with ADPKD. Now we turn our attention to blood pressure monitoring. More frequent blood pressure monitoring, preferably weekly home blood pressure monitoring, is advised in all women with ADPKD who are pregnant. This is most importantly the case in those who already have hypertension or pre-existing hypertension, or who are diagnosed with hypertension during their pregnancy. Next, we want to highlight an important point about postpartum care. Women with ADPKD should be seen by a nephrologist within 6 months after delivery for a postpartum kidney review. Women with ADPKD may have bladder instability or urinary incontinence after delivery and should be offered pelvic floor physical therapy. During postpartum evaluation, we're testing kidney function. We may reintroduce medications depending on lactation state, and we want to return to pre-pregnancy blood pressure targets. That concludes our focus on pregnancy and reproductive issues in ADPKD. Thanks for watching. I also encourage you to take the time to explore the entire collection of videos we've assembled on this guideline. We're all very proud of this work, and we hope it will meaningfully support both clinicians and the people we care for around the world. The full clinical practice guideline can be accessed online at www.kdigo.org.